Okay, good evening, everyone. We will start for those of you who joined us on time. Welcome to another webinar by AB Dental Academy. My name is Irit. I'm the VP of Marketing at AB Dental. I can see with us tonight familiar faces that join us today at 25th anniversary of AB Dental. Thank you all for joining. We are truly honored to host today one of the leading international speakers in the field of oral surgery and implantology, Professor Angelo Cardarelli. Professor Cardarelli graduated with honors from the University of L'Aquila in Italy and later specialized in oral surgery in Sapienza University of Rome. Today serves as an adjunct professor and scientific consultant at the San Raffaele University and Medical Center in Milan. Throughout his career, he has become internationally recognized for his expertise in advanced and oral surgery, implant rehabilitation, and minimally invasive surgical technique. He is now one of our KOL leaders for the past 6 years and working a lot with AB Dental Implants. We are delighted to have him with us today, and I'm sure we are all about to enjoy a highly insightful and inspiring lecture. Our webinar today is all about the I-9 implant of AB Dental, cortical, anchorage, and machined neck for predictable immediate loading. Professor Cardarelli, good evening. Thank you very much for joining us today. The stage is yours. You can start your webinar.
Good evening, everyone, and thanks for joining us this online webinar session about this new implant that we can find in AB Dental portfolio. This is the I-9 implant. And I will show how we can use in our daily practice and which are the main difference comparing the standard implant and the I-9 implant. The I-9 implant is a tissue level implant. So, as you know, in the AB Dental, now we have a new implants, you can find now is the I8 long implant and pterigo implant, a zygoma implant, PSI, of course, and now we have the I9 implant with this machined neck and very aggressive trace. So we will see which are the indication in order to use this kind of implant. Because as you know, we have the indication in order to use properly this implant. So let's start to see the macrogeometry of this implant. As you can see, compared to the standard implant like I5, I55, I2, I22, the design is completely different. Why? Because we have this machined neck. That's why we need to put this implant not bone level, as you know, or below the bone, as we can do using ion, for example, conical connection, but we need to place through the soft tissue. So this implant is soft tissue level. So the application, the preparation, the indication are completely different. If you see the macrogeometry of this implant itself has aggressive traits. That's why the indication is for soft bone and also immediate implant placement in the fresh socket. Why? Because usually if we have a huge socket, sometimes it's difficult to achieve the primary stability with the normal implant. So we need to have these very aggressive traits. So with just few drills, we can prepare the socket and we can place the implant. But don't forget that this is a tissue level implant. So the indications are immediate implant placement in the fresh socket and immediate loading, especially in poor quality bone. Why? Because as you can see here, we have a very aggressive traits, so we can use in soft bone. And which are the sides of those implants? This implant is available in 4, 5, and 6 diameter with different lengths. But look the preparation. In order to place this implant, sometimes, especially in the fresh socket, you need to use only 2-3 drills. Why? Because it's aggressive traits. We have this apex, and with this apex, we can achieve easier the primary stability. So you see here the preparation starting from the pilot drill to the drill 3.2 in order to place, for example, implant 4.0. And in the sides 4.0, we have also 20 lengths. So the maximum length, it will be 20. In the 5 and in the 6 diameter, the maximum length, it will be 16, okay? According to the diameter of the implant. So we can use also, for example, in the pterigo area if you want. But now we have the I-8, so I prefer to use I-8 in pterigo implants. The package is absolutely the same, so nothing different. Also, the surgical kit is the same. You don't need different things. Also, the driver, everything is exactly the same. So you don't need to buy another kit. You can use the same kit that they are using for the internal legs. This is another amazing advantage. So you don't need to change the kit just to buy the implants. Just to buy the implants and getting some advantage in order to use properly this implant. And look this short video. This is the package, and you see here the shape, the macro geometry of this implant is so aggressive. So we have the mounter and we have this machined neck. So we need to put on tissue level. Look, for example, this one is 5 per 11.5 molar area. Look, no, look how we can achieve easier the primary stability. More than 35 Newton. You see here? So just to talk about the difference between standard implant and tissue level implant. Do you know the soft tissue stability is the key in the implant placement? Why? Because in the natural tooth, we have the ligament. We have different attachment and the tissue is more stable. In the implant placement, we don't have the ligament. So the important thing is to keep the soft tissue stability. That's why if you are using, especially in the posterior region, and this is one of the indications for this implant, it will be better to keep the hygiene. Why? Because we have a distance between the connection, the crown, and the bone. So it's easier to keep the hygiene for the patient. So normally we are placing the implant like bone level implant at the same bone level. Or if you are using ion implant, you can put below the bone, like 2 millimeters. But if you are using this I9, it will be different. You see here the placement. It's not bone level, but we need to leave this machined neck in contact with the tissue. Okay? So the placement in terms of the surgical aspect, it will be different, as you can see from this image. Of course, which is the advantage? Using the standard implant, the problem is the bone resorption. You can reduce this risk if you are using conical connection. But if you have the possibility to use soft tissue level implant, it's better. Why? Just to understand the difference between tissue level and bone level. So why tissue level is better in some condition compared to the bone level? Why? Because in the tissue level implant, we have this machined neck in contact with the tissue, and it will be easier to maintain the hygiene for the patient. Okay? The only disadvantage, so be careful. That's why, according to the indication, we don't need to use this implant in the aesthetic region. Why? Because as you know, if we are using tissue level implant, the problem that's you can see the silver of the neck, especially if you have a very thin tissue phenotype. That's why, as indication, we need to use this implant in the perio patient, with the patient with the perio issue, and in the posterior region, avoiding the aesthetic area. avoiding the frontal area. Why? Because we have the risk to see this silver neck. Okay? Oh, sorry, what happened?
And try to share again.
You see now?
Yes.
Okay, sorry. So look how we can put the implants in the bone. So after the preparation, look, in this case, you see the macrogeometry of this implant. Then, according to the level of the tissue, we can decide the depth of the placement, but we need to leave this amount of machined neck outside the bone, above the bone, like tissue level implant. You see here? So the concept, as you can see in this image, is to have this silver neck collar that it will be easier for the hygiene maintenance for the patient. And then we can have, you see here, the placement, this silver neck. The occlusal view, you see, we have the internal legs as usual, nothing different. So we have then the stability of the tissue around the neck, and it will be easier to clean between the crown, the neck, and the tissue. That's why the main indication is the posterior region, especially in the patient with the perio problem, which is the difference with the bone level. So when it's indicated to use bone level, of course in the aesthetic area, as I told before, because we can place the implant at the same bone level or a little bit below. So the indication for the standard implant bone level is the aesthetic area, but it will be different in terms of the hygiene maintenance. Why? Because we have the difficult area to clean between the connection and the restoration. This is the difference comparing with the tissue level implant. So here you see the difference. So implant position between the difference between bone level and tissue level. Bone level, intraosseo placement, subcrestal placement. In terms of the prosthetic part, nothing different, so we can use the same component. The only difference is to see before the amount of the tissue that we have, and I don't use never in the aesthetic zone. So the indication, just to resume, the indication for the standard implant and the indication for this new I-9. So with the standard implant, like bone level implant, we can use in the aesthetic area. We can manage properly the soft tissue contour. So it will be much better in the aesthetic region. So basically, they are indicated for the aesthetic treatment. For the tissue level, the difference is that we have lower incidence of biological complication, as I told before, because we have this silver machined neck, and is excellent for the posterior region, of course, for the maintenance. So let's see how we can use in our daily practice, how we can use in different clinical cases. But in order to achieve the best result using the tissue level implant, don't forget those requirements. So screw and retained restoration, it will be always the first choice. Be careful in order to choose the straight abutment. So the abutment should be straight. Why? Because with the crown, we can close on the top of the machined neck. This is the difference. So if we are using standard T-base, for example, it's impossible to manage the emergence because with the tissue level implant and with this silver machined neck, we can, like BOPT procedure, we can close with the crown on the top of the silver machined neck. This is the difference. And don't forget, you see here, this is the last important things, only original components. Be careful, because sometimes you can have prosthetic issue if we are using not original component. So don't forget this aspect. So one of the indications for this implant is fresh socket treatment with immediate implant placement. Why? Because sometimes it's difficult to achieve the primary stability, especially if the bone septum is so thin. So if you are treating a case like this, so lower jaw, first molar, you see here. So we need to make the extraction. We have periapical lesion. So as you know, according to the protocol, we can treat the patient with the antibiotics therapy and we can put the implant. You see the septum. So just to prepare and look, this implant is I9 5 per 11.5, exactly in the center. High primary stability. You see here. Then we need to lift this machined neck above the bone. This is the main important difference comparing with the normal implant. Look the placement. You see the neck is not below the bone because it's tissue level implant. But you see, it's very easy. Also in the premolar, sometimes in the premolar region, you don't have septum. So just to use 1-2 drill and that's it. You see here, huge socket, no septum. How we can achieve the primary stability? Using this 5 per 11.5 I9. You see here the placement, as usual, a little bit lingual, keeping this space, this small gap between the implant and the buccal bone using grafting material. Nothing different. Then we can use the same healing cap that you are using for internal legs. Nothing different. In this case, as you know, in order to keep the volume, in order to keep and to seal the socket and to seal the graft inside the socket, it's better to use huge healing cap. Okay? As usual, but nothing different. You see the placement and you see the X-ray. So it will be easier achieve the primary stability, especially in the fresh socket. And look also the healing. If you will place properly, you can manage also, you see the emergence, this is only 3 months later. You see the neck is deeper. So also we can avoid the issue to see the silver of machined neck. So if you will place properly, more lingually, and if we have a thick tissue phenotype, you see here, this is tissue level, but it's deeper. You see the profile is so nice. When we will take the impression for the temporary, then for the final. See the occlusal view, see the volume. This is just 3 months later. It's enough. We are ready for the loading because we have a high primary stability. Look the lateral view, 3 months later. You see this contour? You see, it's amazing. Look the occlusal view. Internal X, as you know, but look the stability, the biological width. The biological width is the key. So look the amount of the tissue that we have around this machined neck is stable. Okay? And then we can take the impression and then we can deliver. Also, we can treat case in which we don't have good quality in terms of the bone. Multiple implant placement in the fresh socket. Look this case. The patient in the upper jaw on the right side has some residual dental element with the periapical infection, so she needs to remove. You see here the occlusal view. So we need to remove all of them, premolar and molar. Okay? Of course, as you know, we need to keep atraumatically the extraction in order to preserve the bone. But after the extraction, look, we have this residual socket. So we are planning to place 3 implants. Okay? 3 implants. The placement of those 3 implants should be according to the prosthetic restoration. So we can place 3 I9 implants. Look, with good primary stability, this is the emergence. You see also, I took the impression on the first 2 implants I left the posterior one because the bone there was so soft, and I did immediate restoration. But look here, the occlusal view. So I place it on the premolar, I9 5 per 16. On the second premolar, 5 per 11.5. And in the posterior, 5 per 11.5 with high primary stability. Be careful here. You need to see the level of the tissue in order to place correctly this machined neck. Okay? You see here, with this lateral view, you see here that I left this machined neck above the bone. Okay? This is the protocol for the soft tissue level implant. Okay? Huge healing cap. Look, the healing just 48 hours later. I did immediate restoration. Like this. Okay? You see the immediate restoration just 48 hours later. And then the occlusal view. Okay? I left the posterior one for the osteointegration because there I did the crestal sinus lift and the bone was so soft. That's why. You see? Okay? Of course, also in the upper jaw, in the molar area. Look, if you have the septum, so molar area, we need to use a huge implant because we need to replace the molar. So you see here is 5 per 11.5. You see here, exactly in the center. Okay? So a little bit palatal, as you know, and then we can put grafting material. Look, the X-ray. You see that I want to leave this machined neck above the bone, according to the protocol. But let's see. Just 3 months later, you see different clinical case, but the same result in terms of soft tissue healing. Not only about the osseointegration. As I told before, with this implant, it's very easy to place the implant in the fresh socket to achieve the primary stability. But not only this thing, because another thing is the soft tissue healing. You see here the tissue, the stability of the tissue around the machined neck in the upper molar, in the patient with the perio problem. So you can take the impression, you can deliver temporary, then final. I want to please keep your attention about this final restoration. You see here that the abutment is straight. Why? Because I want to close a little bit with the crown on the machined neck. That's why, and in the future with Ebidenta, we are planning to create this new T-base for tissue level implant. Wow. Why? Because we need this straight abutment. As you can see, because with the crown, we can close the machined neck like this. This is the day of insertion. This is not ideal patient. This is the patient that we have in our daily practice. But look the tissue, look the stability, and look the X-ray. So for the patient, it will be easier, especially in the posterior region, with the floss, to clean and to keep the hygiene around the machined neck. So the best application is the posterior region for this reason. And here, in this case, I want to compare I5 and I9. I5 and I9 in the same patient, upper jaw. The patient came with this residual dental element, so I did the extraction, but look, in the posterior, I found a very huge bone defect, so it was impossible to place the implant immediately. So what I did? Anteriorly, I placed I5, okay, 4.5 per 11.5, I5 implant. Then, posteriorly, I did socket preservation with GBR, bone graft, using xenograft, okay? Just to wait, just to create a new bone. So after a few months, after those integration, I opened again the flap. And I found the I5. And now you see here you can feel and you can see the poor quality of this bone is a regenerated bone, so means D3, D4, so soft. So we have the I5 already placed 3 months ago. Now we need to place the posterior one using the osteotome, no drills, like this, because I want to do crestal sinus lift and I want to preserve the bone. But look the quality of the bone. So in this case, using the I9, like this, we can achieve a good primary stability, high quality, also in this very soft bone. So anterior, we have I5. In the posterior, we have I9. Okay? Same connection. So I took the impression, look the quality of the tissue. When I took the impression, look the X-ray. So I5 compared to I9. Crestal sinus lift, poor quality of bone, high primary stability, soft tissue stability. This is the temporary to manage the soft tissue. Look the difference in terms of the depth of the tissue. If we have anterior I5, posterior I9, you see the amount of the tissue that we have around the posterior one I9? It's thicker. You see here, then we can deliver the temporal and look the healing of the tissue using the temporary restoration. So here you can recognize the advantage of this implant, especially in the posterior, because you see we have this very thicker tissue in the posterior around the machined neck. And here you see the difference, okay? Again, here you see the difference also in terms of the placement, bone level and tissue level. So many cases about immediate implant placement in the fresh socket. Look this case, female patient, no bone septum at all. So sometimes it's difficult to place the implant exactly in the center. Sometimes we are placing more mesial or more distal. But if you have the possibility to prepare with just 1-2 drill, it will be easier. In this case, I used osteodensification barns and I placed my I9 5 per 11.5 exactly in the center. You see here, then you can make bone graft as usual, nothing different. Huge healing cap to keep the volume, and the X-ray, you see, exactly in the center. Look the healing, just 3 months later. I mean the soft tissue healing, because the key in this implant is the soft tissue healing. Look, you see? Then you can take the impression, as usual. Look the lateral view. You see the amount of the keratinized tissue that we have and the thickness of the keratinized tissue that we can keep and how we can increase also in this case in immediate implant placement in the fresh socket. So good soft tissue quality, biological way. You see here the X-ray and the shape of the final restoration. This is the day of the insertion, of course. Temporary before, then final. But you see the day of the insertion, the soft tissue shape is so nice. Okay? This. And look, this is the final X-ray. Okay? So you see here the macro geometry of the implant. Huge implant because it's 5 diameter. This titanium this solely silver machined neck, and for the patient, it will be easier. So why in the posterior region? Because usually we have a foot impaction in the posterior region, and sometimes it's not easy for the patient to use the floss to keep the hygiene. So in this case, also if you have some foot impaction, we have this machined neck. This is the key. That's why the main indication is in the posterior region. Okay? And of course, we can keep the bone volume at the same level. We can reduce the risk of bone resorption. Okay? Other case, molar area, nothing different. You see here the septum. Same implant. Here from this occlusal view, you can recognize the body of this implant. It's so aggressive. It's so aggressive. And good primary stability, nothing different. You see here, again, look the quality of the tissue. Look, it's amazing. It's stable. Look the bone, just 3 months later. Again, temporary, then final. Look, the day of the insertion. So the key is the soft tissue. And if you see here different clinical case, also immediate implant placement in the fresh socket, you see the result. You see how we can stabilize the soft tissue around the implant, around this machined neck. Okay? Again, you see here. So the goal is to have this space, this machined neck, to have a good hygiene maintenance for the patient. That's why in the posterior. Also, again, another case, upper, look, preparation and implant. Tack, easy. Good implant placement, nothing different. Okay? So, in this short introduction, I just shared some clinical cases and some things about how we can use the I-9 implant in our daily practice and why now we have a different option. So, actually, if we have the possibility to use this soft tissue level, and now finally we can find in AB portfolio, it will be much better, but following the indication. So actually, I'm using I9 according to the indication for fresh socket, immediate implant placement, patient with perio issue, with the perio problem, and always in the posterior region. If I need to treat the aesthetic region, the frontal area, I will use standard implant, I5, I55, or I-on, conical connection. So we have many options. I5, I55, bone level implant, aesthetic region. I-on, conical connection, aesthetic region. We can place the implant above the bone. I8, new implant with machined neck, but for pterigo region. Zygoma and I9. With I9, it will be easier to achieve the primary stability also in poor quality bone. So those are the indication, those are the advantage that we can get using this new implant. In terms of surgical procedure, nothing different because we can use the same drills and the same kit. For the prosthetic part, we can use exactly the same analogical way or digital workflow, the same healing cap. The only difference is in the preparation, because with just 1-2 drill, according to the shape of the implant, we can achieve a good primary stability. And of course, we need to manage the level implant placement according the soft tissue. This is the difference, but you can start to use immediately because you don't need a different kit. Okay, so it was just an introduction about the use of this new implant. So now if you have any question or if you want to share your experience, if you have already used this new implant, please feel free and we can talk about and we can open discussion. So if you have any question, please feel free.
You can now unmute yourself to all participants and you can ask Professor Cardarelli questions. We already have questions in
Question.
the chat, Professor.
Sì.
Dr. Vanali Umaranya asks, Sir, what to do if tissue loss is more than expected? This happened with me.
Yes, your question is right. Of course, I think you mean about soft tissue level implant. Yes, sometimes we can have this issue. That's why, first rule, no aesthetic area, because in the aesthetic area, if we have soft tissue loss, you will see this machined neck. So if we have this tissue loss, we have two options. If you have only a few millimeters, you can cover this machined neck with the crown. Okay, that's why you need to have a straight abutment. If this exposure, so if you will see this silver neck more than 3 millimeter, probably you need to add some tissue graft. So those are the different way in order to manage this problem. Okay.
Okay, thank you. We have Dr. Yamir Boudoir asking, I have a case of a patient with HO chronic smoking and completely edentulous maxilla, very eager to go fix prosthesis. Can I use this I-9 implant and do temporization with the existing denture?
Yes, of course. So your question is but you mean poor quality of the bone?
So, due to poor quality of the bone.
Of course, that's why this is the main indication but you have a full arch, you mean, a dental patient.
Yes, yes. Completely dentulous patient using denture.
It's amazing because if you have a dental patient and poor quality bone, it will be easier. Just one, two drill and you will put the implant directly. Sometimes only one drill and you can screw the implant. It's amazing. And you can achieve
And
more than 40 Newton of primary stability. This is one of the indication. Also for full arch, of course, in a dental patient and in poor quality bone.
and can I go for temporization with the existing denture?
Yes, of course. You can put temporary if you have already the temporary the prosthesis, you will follow the analogical way. So you will put the analogical the abutment, and then you can adapt the removable the prosthesis that you have already.
Okay, thank you so much, sir.
Okay, Dr. Michalis Moulius from Greece says hello. It's always a pleasure to follow Professor Cardarelli
Very
and look
much.
forward for the Congress in Athens. That's true. Is asking, are there any heights of tissue levels?
But what do you mean? Are there heights? You mean the heights of the machine in the neck?
Dr. Michalis, are you with us?
Hello.
Hello.
I've followed Professor from the previous Congress in Athens, and I've seen the subperiosteal webinar you had also. I'm looking forward to meet you again, to see you again in Athens.
Yes.
So, Mike,
Also,
yes,
I with you for cadaver course on PSI.
yeah, exactly. I'm going to be your moderator in the Congress. So,
Okay.
uh, oh, I wanted to ask about the machine neck,
The
the
machine at
soft
the neck,
tissue height.
it's the same. We don't have a
It's the
different.
same.
It's the
So we
same.
don't have any levels like one,
No,
two,
no.
five, something like that.
It's
No.
the same. It's the same. It's
Okay.
only
Okay.
one.
Mm-hmm. So, do we know how long it is? The height?
I think is I don't remember. I think is 5 millimeter, 4 millimeter.
It's a long one. So you're right. We cannot use it in the aesthetic area.
But as a general rule, tissue
Yeah.
level,
Yeah.
tissue level like this, no aesthetic area,
Mm-hmm.
of course. course.
Okay, maybe it's something for the AB company, so they can work on it. Maybe we can do like 2 or 4 millimeters, something like that.
Yes, of course, of course.
Mhm. We
No
can
problem.
work on it because it's very important what you have presented today. It's really nice, and if we can have like a small height, like 1 or 2 millimeters, for instance, I think it would be ideal in the aesthetic zone for immediate placement.
Yes,
I
of
don't know
course.
if you agree with me.
Yes, with this
Okay.
implant, the
Hmm.
indication is the posterior. Okay.
Yeah. Yeah, but maybe we can do it in the anterior also if we have a smaller height of the machine neck, like 1 or 2 millimeters,
Yes.
and maybe we can use it in the aesthetic zone also.
Yes, 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 yes. Of course.
Mhm. Okay. Grazie mille, grazie.
Thank you. Thank you very much.
Thank
Thank you,
you,
Dr.
Professor.
Michalis.
Calimera,
Yeah, I'm
Calimera,
looking forward to see you. Okay.
Calimera. Bye.
Okay.
We have with
Bye
us
bye.
Dr. Diana Stancheu. She's asking, hello, how do you close the gingiva around the healing cup? Do you leave the bone graft open?
This is a nice question. So when we are doing this kind of surgery, I never do flap closure. I will do always secondary closure. So how we can manage the socket? Just to use a huge healing cap and to put collagen with slow resorption. And if you have a huge socket, just to X note, but just to hold the collagen inside to protect the graft, but no primary closure. Why? Because if I will do primary closure, you will move the alveolar mucosa on the top. If you will leave like this, you will have more keratinized tissue.
Okay, we have Dr. Turtoi Bogdan with us from Romania. Hello, Dr. Bogdan. Nice to see you again. Is asking, do you always perform the final loading 3 months after the implant placement, or does the time until the loading vary depending on several factors?
Nice question. Not in all cases. If you have mandible case, so lower jaw, 3 months, it's enough. But if you have maxillary rehabilitation, so upper jaw, or if you did the crestal sinus lift, I prefer to wait more. So usually I prefer to wait 4 months in the maxilla at least and 3 months in the mandible. If you are doing crestal sinus lift, you can wait also 5 months. So it depends from many factors. But in the mandible, 3 months, it's enough. Maxilla, 1 month more. 1 month more. If you are doing crestal sinus lift, you can wait 5-6 months. It depends. If you are doing a small crestal sinus lift or huge crestal sinus lift. If you are doing small crestal sinus lift, 4 months, it's enough. If you are doing huge crestal sinus lift, you need to wait 6 months.
Okay, we have Dr. Moskan Dubaria is saying, hello, sir. Is there any chance of neck fracture in machinated one?
No, as you know, the fracture of the neck is related to the thickness of the neck. This neck is so thick. Of course, you need to control the occlusion. The fracture of the neck is related to the occlusion, related to the lateral forces. But in this case, the neck is so thick, so you don't have any problem with the fracture.
Okay, we have another question. Do you mean the machine neck of these implants are going to accommodate the soft tissue above the bone level?
Do you mean the...
From
Yes,
Amireli Rajender.
yes. What do you mean? The concept is the biological width. So if we have a machined neck, you can reduce the risk of inflammation. So the risk of the periimplantitis, this is the difference. So if you are using machined neck, you can clean better this area, this space between the connection and the tissue. So it will be much, much better for the inflammation and to reduce the periimplantitis.
Okay, another question from Gofran Danish Khan. Hello, sir. Is there need of healing cooler in second stage?
What is the... can you repeat the answer? Because I'm
Yeah, is asking, is there need need of healing cooler in second stage?
What do you mean?
I'm not sure. Mr. Gofran Danish Khan, are you with us?
Just to understand better.
Maybe left already. Mr. Amiredi Rajender saying, sir, I have seen in some of the X-ray there are periapical lesions and have gone with placement of I-5 or I-9 implants too. How sure are we that the periapical lesions are not going to affect the outcome of the implant?
Yes, nice question, but I prefer to place the implant if I have infection. Periapical infection is the opposite. You know why? Because if you have an infection, you will have more response from the body and it will be better for the healing. But the periapical lesion is a contraindication for immediate implant placement? No, but you need to prepare properly the patient. So if you have infection, you need to prescribe 3 grams per day, 1 gram each 8 hours, 3 days before the extraction. 3 grams, 1 each 8 hours to prepare the patient. Then you need to make decontamination of the socket. The key is the decontamination, and usually I'm doing this decontamination using piezosurgery tips. So I will go inside the socket for 3 minutes with ultrasound vibration plus irrigation to be sure that everything is completely cleaned. So there is no contraindication. It's the opposite. If you are controlling the infection, you can use the infection to increase the healing of the implant.
Okay, Dr. Elad Ben Elazar is saying, hello, professor, regarding vertical positioning, where do you usually place the top of the machine neck in relation to the bone crest and the free gingiva margin? Do you internationally submerge the machine neck slightly to compensate for expected soft tissue recession? And if so, by approximately how many millimeters?
Yes, this is a nice question. Of course, this question is related if we are talking about especially immediate implant placement in the fascia socket, because the situation is different. Because after the extraction, you need to prevent in the implant placement the resorption of the bone and the soft tissue loss. That's why it depends how many millimeters of tissue you have, and it depends from the thickness of the tissue. According to this, you can place this neck a little bit above to prevent this future bone resorption and soft tissue resorption. So usually, if you have a thick bone phenotype, it will be much better. But if you have a thin bone phenotype, it's better to place deeper. So you need to see the residual soft tissue and the thickness of the tissue. But of course, you need to place deeper, at least 2 millimeters, to prevent this soft tissue recession and bone recession.
Okay, Dr. Tortu is saying, I noticed that you always use provisional restorations to shape the gingiva before the final prosthetic work. What instructions do you give to the dental laboratory regarding the provisional crown, particularly concerning the emergence profile?
Yes. You are right. I'm using always the temporal restoration. Why? Because with the temporal restoration is the only way to manage properly the soft tissue shape. When we are creating this temporal restoration, I ask the dental lab to make a good contour, but there is a rule. In order to create the papilla, how we can create the papilla with the temporal? To manage the distance between the bone and the interdental contact between the teeth. So if the distance, it will be more, you will have less probability to make a new papilla shape. If this distance between the bone and the contact between the teeth, it will be better to have more papilla. I don't know if you understand. Is the interdental contact and the distance between the interdental contact and the bone that can manage properly the papilla.
Okay, Dr. Vanali Umarenia is saying, sir, do you make bone grafts with PRF better compared to bone graft with collagen? There is classification for the papilla field.
Yes, per papilla field there is a classification according to the distance between the interdental contact and the bone. Honestly, I don't find any difference between collagen plus bone and bone plus PRF. Honestly, no difference.
Okay, if there is any other questions, you can
There is a
feel
question
free to
about
unmute.
there is a question about piezo instrumentation. So it depends which kind of piezo surgery are you using. There is a tips with internal irrigation and with the silicone cap that you will put inside the socket for 3 minutes. So you will have cold irrigation plus ultrasound vibration for the decontamination, just to keep 3 minutes inside. It's called piezo clean.
All right, any last questions from the audience? Okay, everybody, thank you very much for joining us. Thank you a lot for Professor Angelo Cardarelli for excellent work and for sharing from his expertise with us. We invite you all to enter AB Dental portal on AB Dental website and register for our next sessions, and of course to our cadaver course in Isernia in Professor Cardarelli's clinic that is taking place this November. Course which is going to be 3 days in Isernia, 1 day of cadaver course, and the second day live surgery done by Professor Angelo Cardarelli. It's an excellent course. It's the third time that we are doing this session together, always fully booked. So I very much invite you all to leave your details on our website, and we'll come back to you with all of the details. And have a great evening. Thank you all for joining us tonight. Thank you, Professor Cardarelli. Always pleasure to hear you.
Thank you.
And see you again in our next session. Bye-bye.
See you soon. Bye-bye.
Thank you.